Hi everyone. We will be starting our session in another 2 minutes. This will be last session, and with this, we come to our conclusion of vaccinator series. We started this session 2 months back because vaccination is a fundamental right of every child and an obligatory duty of part of pediatrician. This is a very important clinical skill which every pediatrician should be aware of. The role of immunization in preventing and controlling vaccine preventable disease has been one of the resounding success stories in child healthcare, and millions of children are going to get affected if not vaccinated well and will be saved if vaccinated well. Till now, we have discussed in the previous 7 talks on benefits of vaccination, what are various vaccination, what are special groups for vaccination, what are the catch-up vaccination schedules, how in special circumstances we need to give vaccination. Today, our talk is about risk involved with vaccination, risk which no pediatrician want in their children, but every pediatrician should be aware of. These are called as adverse effects following immunization, AEFI. Parental anxiety to adverse reaction following vaccination is immense, and that is the reason no pediatrician want a healthy child suffering out of something which is actually meant to make them look better. As definition, AEFI is reported as a medical incident that takes place after immunization, which is a cause of concern and is believed to be caused by immunization. AEFI can be divided into 5 types. That is vaccine reaction, program error, coincidental, injection reaction, and unknown. When we talk about vaccine reaction, it is an event which is precipitated by active component of vaccine. For example, anaphylaxis due to measles vaccine. Program error can be because of bacterial abscess happening secondary to error in vaccine preparation, handling, or in administration. Gastroenteritis, if it is happening after giving DPT, is purely coincidental. So, such event that occurs after immunization but are not caused by the vaccine, there is a chance association. Similarly, a syncopal attack out of anxiety or pain to injection itself in an adolescent after immunization is called as injection reaction. And there are certain set of symptom-based clinical findings which do not have a clear-cut etiology but are seen after administration of vaccine, and they come under the group of unknown, AEFI. When vaccine reaction comes to a pediatrician, it is always a cause of concern because a lot of mental trauma parents have undergone and a lot of questions is what they come with to the pediatrician. So when we talk about vaccine reaction, it is an event which is caused or precipitated by the active component or one of the component of vaccine. There can be local pain, swelling, redness at the injection site, or can be fever, vomiting, malaise to the vaccine, and in rare serious circumstances, even death, hospitalization, and significant disability or incapacity of life-threatening event can also happen. Certain set of vaccines are known to cause certain set of local or systemic reactions, where BCG is known to cause localized pain, swelling, redness in more than 95% of children, and measles is known to cause fever in more than 5 to 15% of children. Pertussis is known to cause 50% of pain, swelling, redness, and 50% of fever, and in 50%, more than 50% cases, actually chances of irritability, malaise, and systemic symptoms have been seen. Inactivated influenza vaccine has 15 to 20% cases with pain, swelling, and redness, as fever and irritability is less known. When we talk about pneumococcal polysaccharide, of after 2 years, around 50%, 30 to 50% will get local reaction. And when we talk about pneumococcal conjugate, around 15 to 24% will get high fever and 10 to 20 will get local reaction. HPV, Gardasil 9, Gardasil 4, 84% will get localized pain, swelling, redness. All these reactions, if pediatricians are aware, can counsel their patient, and these need treatment with oral paracetamol, can be helped with cold fomentation. If there is fever, advice to increase fluid intake, give oral paracetamol. If there is any change in mental status, malaise, or systemic symptoms, encourage fluids, and give oral paracetamol, and always give them ready reference of where to come and meet the doctor in case of an emergency after giving vaccine. Always remember that if you have given vaccine in your clinic, the patient should be in the clinic for next 15 minutes for observation. There are certain serious reactions which can happen after vaccines, such as in BCG suppurative lymphadenitis. It can be seen in 2 to 6 months. Out of million doses, 100 to 1,000 people can have. BCG osteitis, 1 to 12 months, or can be the onset of interval. Disseminated BCG infection, 1 to 12 months. It is seen in 0.19 to 1.56 per million doses. So when we talk about BCG, out of 100 to 1,000 per million doses will have suppurative lymphadenitis, which will come to your OPD one day. If you deal with hepatitis B, anaphylaxis as a reaction can happen in within an hour in 1 to 2 cases per million doses. Measles and MMR are known to cause febrile seizure in 6 to 10 days in 330 to 350 cases per million doses. And the worst outcome can be encephalopathy in less than one case in more than 1 million doses. Vaccine-associated paralytic polio can be seen in an onset of 4 to 30 days in 0.4 reactions per million doses. There can be associated anaphylaxis after tetanus. There can be associated screaming, seizure, anaphylaxis, hypotonic, hyporesponsive episode after pertussis, where primarily whole cell is the factor which is involved. And this is seen from 1,000 to 60,000 cases of persistent screaming out of million doses, which is a significant amount of number. So in private practice, if you choose to give whole cell, as some says that it is 0.3% more immunogenic than acellular, then think again, choose wisely. Program error is another set of vaccine AEFI where it is the wrong handling or error in preparation, handling, or administration of vaccine. It is one of the most common cause of adverse reaction event where even death has been reported once the vaccine has been given into the vein rather than in the intramuscular. These are preventable if you choose the site wisely, what have been told to you while you were in doing your post graduation or while you were getting your clinical skills sharpen up in presence of a clinician. These are completely preventable. You just need to be careful. These are one of the most common cause of infection, and the only problem is non-sterile injection technique. Infection can manifest as suppuration and local reaction. It can lead to sepsis or toxic shock syndrome. It can even lead to blood-borne virus infection, HIV, HBV, HCV, which can further lead to deterioration of patient and doctor relationship and lot of litigations. There are cluster of events which happen because of program errors, and cluster of AEFI is defined as two or more cases of same adverse event related in time, place, or vaccine administered. These clusters are associated with particular provider or health facility or even a single vial of vaccine, which is inappropriate prepared or contaminated. That is the reason in all our vaccination files, we attach sticker of that vaccination batch to safeguard ourselves. Some clinicians have a habit to write that on this date we have given and signed. In case in case there is any reaction and there is a sticker and you dig in deep and you understand that many have got this reaction, then you are at least safe that it is not your mistake, it is manufacturer's mistake, and then you can actually help the patient in doing justice and you can support the patient in finding the right cause. So in a nutshell, it is non-sterile injection, which can be because of reuse of disposable syringes or needles, improperly sterilized needles or syringes being used, contaminated vaccines being used, local suppuration at injection site, abscess, cellulitis, and still injection was given, contaminated vaccine or diluents have been used. There is a systemic infection, sepsis, toxic shock syndrome, or bloodborne infection and HIV, HBV, HCV by using poorly disinfected needles or non-disposable needles have been utilized. Sometimes vaccine given at improper sites, such as subcutaneous instead of intradermal in BCG, Hep B and anti-rabies vaccine given in gluteal region, DPT-like vaccine not given by deep IM route, BCG adenitis happening in and local reaction like induration nodule formation after PCV. So when incorrected prepared vaccine is the cause of the program error, then ensure that your staff is adequately trained. You keep the vaccine safe. Constitution is done in your presence. Drugs are substituted for vaccine or diluents properly, and when similar looking drugs are not kept together in which if you are using fridge for storing vaccine and insulin. So ensure that these type of mistakes should not happen. If your storage is not adequately done, which we have discussed on the first week of April, how to use normal fridge as a vaccine storage device, then your effectiveness of vaccine is also gone. Increased local reaction happens from frozen vaccines, so don't use frozen vaccines. And also remember that if the vaccine is frozen while it has to be kept in 2 to 8, then efficiency of vaccine is also gone. There are certain set of reaction which happen coincidentally, such as an event of SIDS following vaccination or acute gastroenteritis following DPT, which are purely coincidental, and this has happened not because of vaccine, but there's a chance association. Other set of reaction which are seen in pediatric age group are anxiety to pain from injection, syncopal attack due to pain or look of injection. Now it is not gender biased, but out of two, male are less prone for syncopal attack. But this is completely skewed data, and there is no specific gender biasing. Syncopal attack and anxiety attack are commonly seen in both the genders. Biggest set of AEFIs are unknown, where event is not determined by usage of vaccine. There can be anaphylactoid reaction where exaggerated allergic reaction is characterized by one or more, that is bronchospasm, laryngospasm, or hives, facial or generalized edema. It can occur within 2 hours of vaccination. It is usually self-limiting. It is less severe and need not to be reported. In comparison to that, anaphylaxis, which can happen to any vaccine, incidence is 1 per million doses. There is generalized urticaria, hives, wheezing, facial edema, bronchospasm, laryngospasm, cardiac involvement with hypotension and shock. It can occur within 1 hour post-vaccination. Precautions are only that child should be observed for 15 and phenylephrine diphenhydramine in your ER or in your practicing clinic. Ensure that these vaccines should always be given and observation of 15 minutes is kept. IM EpiPen is not easily available in India. So we have racemic mixture of ADR 1 is to 1000. 0.1 ml per kg can be given when you are using, and 0.3 mg is the maximum dose of ADR which you can give. AEFI presentation and management with disseminated BCG infection is commonly seen in immunocompromised children where widespread infection happens in 1 to 12 months after BCG vaccination. It is confirmed by isolation of Mycobacterium bovis and treatment is ATT including rifampicin and isoniazid. When we talk with encephalopathy, it is common common with symptoms seen. Incidence is very less, but symptoms will be acute onset of either seizures or altered level of consciousness or change in behavior for more than 24 hours. In measles, it has been reported in a less than 10% or less than 10 per million doses, and in 7 to 12 days, it has been seen within 48 hours with pertussis. There is no specific treatment, only supportive care, and you have to evaluate as you evaluate a child with encephalopathy. Fever ranging from 100.4 to 102 and 102 to 104 and above 104 can all be seen with any of the vaccine. Symptomatic treatment by regularly giving them paracetamol or encouraging them to have more oral fluids with tepid sponging, which is not recommended with no evidence behind it, but still is in practice with no harm, can be utilized as a practice. In my personal opinion, giving in more fluids after vaccination is a very helpful way to take down the temperature, and keeping a standby of paracetamol if needed to be given should always be mentioned so that the parent and patient should not be left hanging to, and they are not aware what to do if at all fever is there, because as a clinician you cannot understand who will get fever and who will not. So as a dictum, encourage your parents to increase fluid intake. If child is less, increase milk intake, and always keep a right dose of paracetamol ready with the parent. If at all they see fever, let them give it. Another subset of popular problem called hypotonic hyporesponsive episode, HHE or shock collapse, where there is sudden onset occurring within 48 hours, usually less than 12 hours, lasting for 1 minute to several hours in less than 10 years of age, where features of hypotonia, reduced responsiveness, pallor or cyanosis, or failure to observe or recall is the cause, and usually seen with DPT vaccine, transiently happening, and it is self-limiting. It is not a contraindication for further doses, but when we give DPT, which is regular till the end, then hypotonic hyperresponsive episode should also be in your mind. And if at all 15-minute observation is over, then at least you will be happy that this probably is not going to happen. But you should be sure. And if patient comes with such presentation, then you should be ready with this diagnosis, and you should be ready to discuss all the treatment option with your patients. When we deal with injections, we are dealing with risk associated with injection, where toxic shock syndrome should never be forgotten. There can be abrupt onset of fever, vomiting, and watery diarrhea within few hours of immunization. If not identified and not treated adequately with right antibiotics in the early course, it can even lead to death. It is a possible indicator of program error. Another subset of popular problem called vaccine-associated paralytic polio is acute onset of flaccid paralysis happening in 4 to 30 days of OPV recipient, or 4 to 75 days of contact with vaccine recipient, where neurological deficit remains for 60 days after onset. Death can also happen with respiratory failure. Technically, there is no specific treatment, but only supportive care. Generalized convulsions that are not accompanied by focal neurological signs in some set of children after vaccination, with febrile seizure happening at rapid rise in temperature going above 100.4 or 38 degree, or a febrile seizure when temperature is normal, then seizure related as a complication of AEFI can also be targeted under an unknown category of AEFI. These are self-limiting. Supportive care is needed. Paracetamol and rarely anticonvulsants are needed. With the presence of many super specialists in tier one cities, and availability of MRI and other services, nowadays it is easier to understand what kind of autoimmune nature or what kind of etiology is causing this fever. Mainly, pertussis and measles are the vaccine which are associated with seizures and should always be kept at the back of mind by the treating clinician. Injection site abscess, that is fluctuant or fluid-filled lesion at the injection site, and bacteria coming as evidence of infection leading to purulent fever with inflammatory sign. That means there is a program error and the abscess was created because of poor hygiene being utilized at the time of injection. It can happen with all injectable vaccines. Treatment is IND and antibiotic if it is bacterial. When the child is treated and there are at least one lymph node after vaccination which is more than 1.5 centimeter in size, that is around one finger breadth by an adult, or there is a draining sinus over the lymph node, that means you're dealing with lymphadenitis. It is exclusively seen with BCG, occurring within 2 to 6 months after receipt of BCG vaccine on the same site of inoculation, mostly in axillary lymph node. It heals spontaneously, and it is best not to treat unless lesion is sticking to the skin. If there is skin infiltration or there is already draining, surgical drainage and local installation of ATT drug is provided. Systemic treatment with ATT is generally ineffective in BCG rhinitis. Very rare complication of osteomyelitis has also been seen, where inflammation of bone with isolation of Mycobacterium bovis BCG strain, with where treatment of ATT including isoniazid and rifampicin has shown results. Today we have managed a child with a hematoma at the site of BCG, and child is under evaluation. So as we are progressing, more and more cases with different presentation coming up with problem of tuberculosis, where we living in top tropical country need to understand that TB can come in any form. When we talk about vaccination, another important aspect is sepsis, which is actually the acute onset of generalized illness due to bacterial infection. It is confirmed by blood culture. and it is most likely indicator of program error where infective component got injected in the body and spread all across the body. And it can happen with any of the injectable vaccine if there is predisposition of program error. Early antibiotic, early fluid management, early inotropy if needed is most important in managing such patients. Persistent inconsolable screaming seen with pertussis mainly, where the cry can happen for 3 hours or longer, where high pitched screaming can happen and it settles within a day. Analgesics may help, and whole cell pertussis seems to be the cause, and 60,000 out of 1 million doses is a big number. Those who have a habit of whole cell pertussis must have seen such kind of complication. So they must have figured it out that only rest and analgesia works in such cases. Severe local reaction, that is redness or swelling at the site of injection, and where the swelling is going beyond the nearest joint, pain or redness and swelling is happening for more than 3 days of duration, needs hospitalization. It can happen with any injectable vaccine. I have noticed it with pneumococcal, and although any vaccine is can cause this, symptomatic treatment with analgesics, hot and cold fermentation as per the choice of the patient and on the response of the patient is usually needed. There is no specific etiological or there is no specific age or gender which is more prone for such complication, but it can happen with any of the individual who come across to us. Here we conclude AEFI as a topic, but as a pediatrician, none of us wants any of our patient to have any of these complications. As a clinician, I would only like to request all the participants to ensure that you maintain cold chain, you ensure that vaccines are prepared in your presence, you ensure that your support staff is adequate enough to check for expiry of the vaccine, and diluents are not um freezed, and vaccines are not without room on are not kept on room temperature without cold chain. There should be clean site. If at all there is any evidence of infection, you don't proceed. Defer vaccine if you have a doubt on the patient well-being. Do not take any kind of risk with your practice. Litigations are on rise. It is clinician responsibility to safeguard our own interest. Reference for this has been IAP Guidebook on Immunization. AEFI haven't changed. CDC has supported this activity, and every day in day out after COVID, there is a lot of changes in perception of the people that COVID vaccine has caused this side effect or that side effect. All those kind of side effect can happen actually with any vaccine. There is no one vaccine which increases our body immune status, and there is no one vaccine which cannot cause clotting mechanism defect. Only thing is it affects at uh, it affects different individuals because of various comorbidities. Do not um, fall for the propaganda that vaccines are harmful. Rather, utilize your knowledge and improve your practice. With this, I will conclude this talk, and thank you for being participative. Thank you for being available in these hours. It is a great journey. And if at all there are any questions, we'll be taking on the group. With this, I will end this talk. Thank you for joining, everyone. If at all there are questions, kindly post on the vaccination group. Thank you.